Good evening, everyone. Welcome you all for today's Fellows Talk. And so we'll start with Dr. Rutul. And so I welcome Dr. Rutul and Dr. Mamta for this amazing topic. And we'll start with the diabetes. So, sir, up to you. Thank you so much for taking this opportunity.
Thank you very much, Navya and Dr. Laharia, for inviting me and having me here and giving me the chance to talk on my favorite topic. And this is actually uh, primordial prevention and uh, that primordial prevention through GDM. So, primordial prevention of type 2 diabetes. Is GDM the way forward? And this is my today's topic is, and I hope it would be thought provoking, and we will have a great discussion after this talk. So if you overall see hyperglycemia in pregnancy in women between 20 to 50 years of age, by IDF region, Southeast Asia has the highest number or highest prevalence of hyperglycemia in pregnancy. It's not only about GDM, but it is about overall hyperglycemia in pregnancy. So maybe type 1 diabetes, type 2 diabetes, pre-diabetes, or diabetes in pregnancy. So 1 in 6 live births occur to women with some form of hyperglycemia, and 84% of which are due to gestational diabetes. So if we really see, most of hyperglycemia in pregnancy are gestational diabetes, but around 15 to 16% of the cases are type 1 diabetes, type 2 diabetes, or pre-diabetes, that is actually pre-existing diabetes, or we call it diabetes in pregnancy. Also, what are the concerns for this? GDM represents detection of chronic beta cell dysfunction. So it is actually the test for pancreatic beta cell during gestational period. If they pass it, then there are very less likely chances of women having type 2 diabetes in future. But if women had gestational diabetes, that means that their beta cell of pancreas are already somewhere compromised. So GDM is the stage in the evolution of type 2 diabetes. We know this slide, this is nothing new, but like GDM effect on mother and baby, and two lives are really affected. So what kind of complications mother have? That is preeclampsia during pregnancy. During labor, it may cause induction of labor, cesarean section, operative deliveries, labor complications, postpartum and beyond, like more recurrent GDM in second or third pregnancy, and maybe type 2 diabetes in future. But in baby, there are multiple problems that may be in congenital phase or neonatal complications, or long-term outcome like obesity, type 1, type 2 diabetes, or other metabolic problems. So lifetime risk of type 2 diabetes increased in women with gestational diabetes. It is up to 50% of GDM women developed impaired glucose tolerance within 5 to 10 years, which is quite shocking. So mother who has gestational diabetes, out of those 50% women will develop either pre-diabetes or complete over type 2 diabetes. So women with GDM have tenfold increased risk of development of type 2 diabetes than women with no GDM, and absolute risk increases linearly through a woman's lifetime. So 20% risk at 10 years, 30% risk at 20 years, 40% risk at 30 years, and 50% at 40 years, and 60% at 50 years. So there is increase in risk who had gestational diabetes. Women with GDM are at higher risk of premature cardiovascular disease as well. So here I have not mentioned cardiac study, but it is also very important that women with history of GDM have higher prevalence of metabolic syndrome and increased risk of cardiovascular disease. And over 10 years, women with GDM had more non-invasive cardiac diagnostic procedure, simple cardiovascular events, and total cardiovascular hospitalization after adjusting for age, ethnicity, and comorbidities such as preeclampsia and obesity. So post GDM, there are very high chance of all kind of metabolic disorders, including cardiovascular diseases, and even increase in cardiac diagnostic procedure and cardiovascular events in women with GDM. So we can say that the future for women is not so good, but for baby it is also the same. So diabetes begets diabetes. So if you really see, GDM may be responsible for 19 to 30% of the cases of type 2 diabetes among Saskatchewan First Nation people, and that was published in 2011. Uh, Also, we can say that offspring of GDM pregnancy at higher risk of metabolic problems, including type 2 diabetes. So the baby who is born to GDM mother has higher chances of metabolic problems. So not only mother, but baby is also affected same. So around 50% of diabetes in youth is attributed to uterine exposure of maternal obesity and diabetes. This is very big statement, and all of you should take it very seriously, that 50% of diabetes in youth is attributed to uterine exposure of maternal obesity or type 2 diabetes. So definitely two lives are impacted by GDM, where if you see, diagnosis of GDM identifies women at higher risk of future diabetes and associated with metabolic problems. So that already we discussed, but maternal hyperglycemia is associated with development of metabolic problems in offspring as well. So hyperglycemia during pregnancy is associated with high risk of maternal and perinatal morbidity and mortality. So it is a window of opportunity for primary prevention of all NCDs, non-communicable diseases, and cardiometabolic disorders. So we all must have heard about Chanakya, and what Chanakya had said in that ancient time, that even as the unborn baby is in the womb of his mother, these five are the fixed as his life destiny, his lifespan, his activities, his acquisitions of wealth and knowledge, and his time of death. So already when the baby is in the womb, everything is pre-decided, as we know about garb sanskar that is commonly given nowadays in babies. So garb upanishad, what they say, that part of Krishna Yajurveda explaining details about the conception and growth of child in the mother's womb and its spiritual connection. Also, in 19th century, Dr. David Barker came up with idea, and he conceptualized that the body's susceptibility to lifestyle diseases or metabolic disorders was programmed intrauterine. So everything is decided in uterine, whether this child will develop metabolic disorder or not. So this was conceptualized way back in 1960 by Dr. David Barker. So what exactly is the fetal origins of disease hypothesis? So Dohad theory, where the hypothesis states that the susceptibility to cardiovascular diseases and non-insulin dependent diabetes mellitus and insulin resistance syndrome is programmed in utero. So not only diabetes or any blood pressure, but insulin resistance syndrome overall is decided in utero only. So exposure during a critical period in development may influence later metabolic or physiological function in adult life, and adverse environment in fetal life and early childhood lead to increased risk of disease in adult life. So if you really see DOHAD theory, that is developmental origin of health and diseases, where definitely phenotype or genetic on top of genetic problem, there are epigenetic factors or environmental factors. So there is genetics loads the gun and the environment triggers it off. So environmental factors like uh, decreased physical activity or a bad eating pattern are the epigenetic or environmental factors, whereas the gene has been given by parents, which we can't change, but definitely epigenetic factors can be changed. Maternal metabolism in pregnancy changes physiologically to provide an uninterrupted nutrient supply to fetus for its growth and energy needs. So blood sugar of mother is free flowing to baby due for its growth. So fetus is a continually feeding border in an intermittently eating host mother. So mother eats intermittently, but baby gets nutrients continuously. So maternal glucose concentration, where fetal genetically determined responses, it enhances glucose sensing by fetal pancreas. Fetal pancreas is ready by 8 to 10 weeks of gestational period, and insulin secretion by fetal pancreas starts around 10 weeks of pregnancy. Insulin mediated growth starts at 10 weeks, and infant's birth weight is actually determined by this insulin related growth itself. So we know about Pedersen's hypothesis in 1952. Still, this hypothesis is very much relevant, and it says that macrosomia is due to carbohydrate surplus of fetus and stimulation of pancreas due to this carbohydrate surplus, and insulin is increased in baby, and that stimulation of protein, lipid, and glycogen synthesis, and also stimulatory effect on development of beta cells and release in insulin like growth factor are also reason for macrosomia. Organomegaly, hypoglycemia, polycythemia, and respiratory distress syndrome. And another hypothesis is Frankel's hypothesis, where fetal overgrowth is function of multiple nutritional factor. So at birth, when we know that there is macrosomia in the baby, and that is due to overfeeding and higher insulin requirement due to hyperglycemia in mother, and that leads to non-communicable diseases after birth, and it leads to obesity, metabolic syndrome, impaired glucose tolerance or diabetes, and cardiovascular disease. But what is that new modified Frankel's or Pedersen's hypothesis, the effect on maternal fuel of offspring development? So definitely male child, after this macrosomia, this male child has higher chances of obesity and impaired glucose tolerance, or in future at very early age, around 20 to 25 years of age, they get diabetes. But what happens in female who has female offspring who also has obesity, and they lead to gestational diabetes, and ultimately this cycles goes on and on, And this is how this gestational diabetes makes the difference. So women with a history of GDM are at increased risk of future diabetes, predominantly type 2 diabetes. Diabetes as are there in children, and it is called transgenerational transmission. So we call it transgenerational transmission, and this term was coined by Dr. V. Seshia sir, who is the father of GDM in India. So what is the reason of this organomegaly and everything? It is maternal overnutrition, which is very much common in India during pregnancy. That maternal overnutrition, in utero overnutrition happens, and epigenetic changes in genes like MEST, PPAR alpha, and ABCA1, and ultimately it leads to altered physiology and insulin resistance and beta cell dysfunction occurs, and which increases risk of obesity, diabetes, and cardiovascular disease in offspring, and also intergenerational effect and long-term non-communicable diseases occurs. So again, Dohad theory, which leads to environmental exposure, can lead to establishment of epigenetic modifications such as histone modification, DNA methylation, and non-coding RNA mediated regulation. And among this, DNA methylation is currently the best characterized. The persistence of this modification later in life may condition the offspring to develop metabolic disorders such as obesity, type 2 diabetes, and cardiovascular diseases. So ultimately, this Dohad theory says that this offspring has higher chances of type 2 diabetes at a very early stage of the disease. So GDM may play a crucial role in the increase in prevalence of diabetes and obesity. So origin of cardiometabolic disorder is there. So fetal overnutrition due to GDM and or maternal obesity leads to epigenetic changes in exposed offspring. Epigenetic changes in numerous other genes may increase the lifelong metabolic disease susceptibility, and thus the likelihood of new generation of mothers with GDM and obesity feeding the vicious cycle. And consistent with the decreasing plasticity of epigenome, the effect of possible intervention to break the cycle can be expected to be larger in than preconception and perinatal period than after birth during infancy. So during pregnancy only, we should control the blood sugar of mother so that baby does not realize that mother has any kind of hyperglycemia. So blood sugar should remain as normal as a non-diabetic pregnant woman. So we should try to keep fasting blood glucose less than 90 and post-meal blood sugar at least less than 120, or if it is a pre-gestational diabetes or pre-existing diabetes, we should try to keep it less than 130 mg per dl. So GDM may play a crucial role in increasing prevalence of diabetes and obesity. Therefore, universal screening and prompt management of pregnant women for glucose intolerance is very essential, and this is public health priority nowadays. Lifestyle and pharmacological intervention to delay or prevent the onset of overt diabetes is important. GDM, where if diagnosed, then we can intervene with medical nutrition therapy or insulin or metformin now, as metformin is also approved these days. That newborn has appropriate newborn with appropriate for gestational age, so there is no macrosomia. So this is how only we are going to prevent obesity and IGT in offspring. And so preventive measures against type 2 diabetes should start during intrauterine period and continue throughout the life from early childhood. GDM offers an important opportunity for the development, testing, and the implementation of clinical strategies for diabetes prevention. So maternal undernutrition and overnutrition, they both lead to Barker's hypothesis or Pedersen's hypothesis of low birth weight and macrosomia. It predicts the development of hypertension, type 2 diabetes, and IGT. And the solution is optimal birth weight of the baby, which actually can prevent non-communicable disease in the most beautiful way. So female gender, the key to diabetes prevention. This was given by Lise Kingo. Then low birth weight that leads to or large for gestational age birth weight. This both can lead to elevated risk of obesity, diabetes, hypertension, and cardiovascular disease. And this is the intergenerational transfer of the risk. So maternal health is the link to the non-communicable disease epidemic. And for that, we have goal not only to improve perinatal outcome, but also to prevent long-term maternal and fetal effects. If glycemic control can be maximized to extent that the fetus no longer recognize, this is very important, that fetus should not realize that her mother has hyperglycemia, as blood glucose is free flowing to baby as well. And as baby's blood glucose is increased, his or her pancreas also is stimulated twice or thrice. So baby has hyperinsulinemia and overgrowth occurs. So baby should not recognize that its mother has diabetes. Then the treatment of mother during pregnancy may become the first step in prevention of obesity and diabetes in offspring. So pregnancy offers a window of opportunity to provide maternal care service. It reduces traditional maternal and perinatal morbidity and mortality indicators and addresses intergenerational prevention of NCDs such as diabetes, hypertension, cardiovascular disease, and stroke. So to conclude, we have a clinician are afforded the rare opportunity to alter the natural course of disease and change the future health of women and their offspring today. So GDM is window of opportunity to prevent NCDs, to achieve diabetes-free generation, focus on the fetus for the future. This sentence again given by Professor V. Seshia sir, the father of GDM. With this, I would conclude. And if we have the question, you can ask it right away or maybe after Dr. Mamta's talk. Thank you.
Thank you so much, sir. Any question if anybody I want to ask? Or we'll continue with Dr. Mamta. Sir, but one thing I personally like the example of that Chanakya and the ancient history, that is so good. Like we learn a lot. Thank you so much.
Thank you. Thank you very much.
So I guess we will continue with Dr. Mamta. Ma'am, you are on mute.
Am I audible now?
Yeah, sure. You can start.
Okay, I'll just share my screen. Is it visible?
Yes, it is visible.
Okay. Good evening, everyone. Myself, Dr. Mamta. I am working as a scientist C at RCHTA AIIMS Jodhpur, that is Health Technology Assessment. First of all, I'm really grateful and I appreciate for giving me this chance to express myself and present here. And Dr. Rutul sir, it was very well explained in a very good presentation. The topic I had selected this topic because HTA is a very new concept in India, and people are not aware of it. So, what is HTA? What is Health Technology Assessment? So it comes under DHR, that is Department of Health Research. DHR established a mechanism for health technology assessment for the evaluation of appropriateness and cost effectiveness of the available and the new health technologies in the country. It was established in year 2017, that is HTA in India. Health Technology Assessment in India was established in 2017. HTA is entrusted with the responsibility to analyze health technologies like medicines, devices, health programs for its cost effectiveness, clinical effectiveness, and the equity issues, and in term helps in decision making for an efficient use of the limited health resources or limited health budget of India, and provide the people access to quality health care, reducing the out-of-pocket expenditure on health. It is a multidisciplinary decision-making process that uses the information about the medical, social, economical, organizational, and the ethical issues related to the use of health technology in a systematic, transparent, unbiased, and robust manner. It is a tool for evidence-based decision-making for healthcare benefits. It acts as a bridge between the evidence and the policy making. It seeks to provide health policy makers with accessible, usable, and evidence-based information to guide their decisions about the appropriate use of technology and the efficient allocation of the resources. Now, HTA broadly focuses on two questions, that is clinical effectiveness and the cost effectiveness. In clinical effectiveness, we see that how do the health outcomes of the technology compare with the available treatment alternatives? And in cost effectiveness, are these improvements in health outcomes commensurate with the additional cost of the technology? Coming to the structure of HTA-IN, so this is the structure. First of all, we see in the center, that is HTA-IN Secretariat. So DHR, this HTA-IN Secretariat is a in-house body of the DHR that coordinates between the user departments, the TAC, that is Technical Appraisal Committee, the RRCs, resource centers, and the technical partners. It comprises of scientists, health economists, policy analysts, consultants, managers, data entry operators, multitasking staffs, and it provides the assistance to the resource centers and the technical partners by conducting meetings. Then we come to the board. So the board was set up in 2017, as I mentioned, to take the final policy decisions on the recommendations of the health technology assessment studies. It includes the policymakers, the clinicians, bureaucrats, experts from the different government bodies, and it is the highest decision-making body of the HTA in India. Then coming to TAC, that is Technical Appraisal Committee. It is a multidisciplinary body. It also comprises of economists, clinicians, researchers, social scientists, health policy experts, and it ensures the appraisal of the study at the different stages. It does the quality assurance and provide the overall stewardship to HTA-IN. Then coming to the stakeholders or the user departments. These are the central or the state government bodies, NHM, RSBY, public health authorities, policymakers, medical insurers, regulatory agencies, academicians, social groups, NGOs, who have the direct interest in the process or the outcome of a particular study. This is a list of the resource centers and technical partners in India. This you can see PGI Chandigarh, IIPH Shillong, RMRC Bhubaneswar, KIHT Vizag, NIRT, Chennai, SCIMST Trivandrum, Mumbai, IIPH Gandhinagar, NIE Chennai, JIPMER, AIIMS Rishikesh, AIIMS Jodhpur, IIPH Hyderabad, NIV Pune. 16 are listed here, and as of now, there are 20 resource centers in India, and we have 10 technical partners. The technical partners are which are showing in green color: the AIIMS New Delhi, NIMS New Delhi, NHSRC, IIT Mumbai, Nari Pune, IIHMR Jaipur, Bhubaneswar, IIPH, and IIT Chennai. So what are the objectives of HTA-IN? First is to maximize the health, expanding the coverage without compromising the quality of the healthcare services, reducing out-of-pocket expenditure, achieving the reduction in the proportion of catastrophic household expenditures and the consequent impoverishment, and reducing inequality, minimizing the disparity on the account of gender, poverty, caste, disability, and the other forms of social exclusion and geographical barriers. So the key phases of HTA process: first of all, the topic is selected, and then the technical partner is identified that which technical team should go ahead with the topics. The RRCs develop the proposal. AIIMS Jodhpur is a RRC center of HTA-IN. So there are many. I showed there are 20 in total as of now. So it is identified that which RRC center should be given the topic. Then the RRC develops the proposal. Research is done, then analysis is done, and appraisal of the evidence is done. Then it is approved by the board, and implementation is done by the user departments. Coming to the model for HTA, we all know that there is a PICOT formula. Population, P is for population that is to be included, I is for the intervention, C is the comparator, O is outcome, and T is the time frame for assessment. This is the same thing, PICOT framework. Now, what are all the steps that is included in the topic prioritization? Topic prioritization is a very important aspect in HTA-IN, at which all topics should be assessed and how to prioritize the topic. So, first step is topic identification, then topic selection, and then topic is prioritize. So coming in detail about this, how to identify the topic, the step where topics potentially suitable for HTA are identified. Topic could be publicly financed or covered by compulsory health insurance or included in health benefit packages. We may have different HTA processes for different health technologies and patient groups. Example, one process for prescription medicines, another one for medical devices or childhood vaccines. Then the second is to select the topic, the step where details on the topics are collected and the identified topics are checked for conformity with the aims of HTA process. If the HTA process is set up for the childhood vaccination, any vaccines identified as not suitable for children will be excluded here. Then the most important step comes is prioritization. The step where a decision is made to either initiate, reject, or postpone the commencement of an assessment, taking into account the best use of limited resources and the context-dependent values. HTA system has limited capacity to access all health technologies, and therefore prioritization is done. Topic prioritization is a task typically given to specialized committees of clinical experts and stakeholders. These committees use implicit judgment, example, influenced by individual experiences, ranking according to assumptions, or explicit judgment. Just to explain the same with the diagram, we identify the topics. There are many topics, and then selection is done in scope of HTA system. Here you can see now the topics selected are less and some of them are again excluded. Coming to the prioritization, the topics are again excluded from this, and then the topic is selected and HTA is done. So in beginning, we see that there were so many topics, and coming to the prioritization, we have a limited number of topics and which are feasible to be done by the HTA-IN. What is the criteria for the prioritization of topics for HTA? The burden of the disease is looked upon, availability of the alternative technology, clinical effectiveness, economic efficiency, budget impact, and the ethical, legal, and psychosocial aspects are seen. This is given by HTA, an algorithm to guide choosing the right HTA topic. So we can see here, when we get a proposed topic for HTA study, first it is seen that does the topic of interest address an important unmet need? If no, the topic is not taken forward. The proposed topic is not appropriate for HTA, and here only the topic is closed. But if the answer to the question is yes, then the second thing we need to see is, can an HTA in the topic of interest result into an improved treatment, screening pathway, or prevention scheme? Again, if the answer is yes, we'll move forward. Is there any RCT evidence on effectiveness, diagnostic or screening accuracy, or preventive capacity of the intervention? If the answer is no, again, the process is stopped here. But if the answer is again yes, we will move forward and ask for, can the benefit associated with the intervention of interest be measured in terms of survival, quality of life of patients, or events avoided? If yes, this is a good proposed HTA topic, and the topic is taken forward and economic evaluation of the topic is done. Future roadmap. India has taken a big leap towards evidence-based policy making by establishing the HTA-IN. But there are many challenges we look to. The first and the foremost challenge for HTA in India is to build a community of credible HTA researchers. The second challenge is to develop the data and the systems that facilitate robust HTA studies. And the third challenge involves the enhancing uptake of HTA research for policy. The journey of HTA in India has so far enjoyed the support of political leadership, policy makers, as well as researcher community. However, these are very early days. It is a very naive, HTA is very naive in India. Ensuring that political goodwill and support of the policy community is maintained and enhanced, it would require evidence that the decisions which were shaped through HTA have had a positive impact on health outcomes and improved health sector performance. These are the references I used to make this presentation. Thank you for listening. Over to Dr. Navya.
Thank you, Dr. Mamta. It was interesting. I would request like fellows, can you please ask if you have any questions?
Yes, please. I have a small question. Thank you so much. It was a wonderful presentation, Dr. Mamta Patel. My question is, you mentioned about the researchers there. What is the way forward if at all a researcher is interested in the digital health platform? And how do we go about?
Ma'am, you are not audible. There was a connection error, I guess. Can you please repeat?
Yeah, Mamta, I asked if at all there is a researcher who is interested in the digital health, what is the way forward and how does this organization support? Thank you.
Ma'am, first of all, from which state you are, I don't know. So there will be a HTA team working there in your state. So the topic, we have to give this topic to DHR. In coming time, HTA will be open to industries and public. So there is a portal, HTA-IN portal, where the interested researchers, so they can keep their ideas, and it may be taken forward by the RRCs after the board or the secretariat gives the topic to the respected RRCs. For now, I guess you need to contact to HTA-IN in portal. You can mail or something like that, but it is not yet open to industries and researchers.
Thank you so much.
Hello. Yeah, Navya, can I ask the next question?
Yes, Vaibhav, you can.
Yeah. Hi, Dr. Mamta. It was great presentation. I just wanted to know that if we plan to proceed with the HTA on a particular topic, and if the data is not available, in such cases, what do we do? If it is because HTA is mostly done on novel technologies, and mostly we, what I understand is we take data from the published meta-analysis. So how do we proceed in such scenarios?
Right, right. Thank you for asking this question, Vaibhav. Mostly HTA is done on secondary data, it's true. But if there is no data available, a primary study need to be planned and data has to be created. If we don't have a systematic review or meta-analysis done, we can plan a systematic review, and then we can further do the economic evaluation and everything. But if you don't have a primary study also, then a primary study need to be done on the topic. Then only, without that we cannot proceed.
Yes. Okay, that means we need to have something, some primary data.
Right. We need to have some data.
Yeah, exactly. If nothing is available in terms of published systematic review or something, then we need to gather that. Okay.
Yeah, if we don't have systematic reviews can be done, no? If we have a data available, but if you don't have any data available, any studies is not done on a particular topic, then a primary study has to be done, and then it is taken.
Oh, thank you.
Okay, thank you, Weber. And so anything else, if anybody want to discuss anything about HTA or diabetes? So, okay, so I think there are no more question. Thank you so much. Thank you, Dr. Rutul, and thank you, Dr. Mamta. So the both
Thank you very much,
presentations
Navya
are,
and everyone.
yeah. So the video will be uploaded on the YouTube so that other fellow can access it. And so thank you everyone for joining today.
Thank you, Navya. Thank you all for
Goodbye.
listening. Bye.
Thank you.
Goodbye. Goodbye, Dr. Mamta.